Thank you, Dr. Atif, for your kind introduction. So, good afternoon, ladies and gentlemen. Welcome to Takeda Symposium. In this afternoon, we're gonna talking about the new era for the management of acid-related disease in ASEAN. Since 1989, the PPI was first introduced, and PPI has been a mainstay for the treatment of acid-related disease. But right now, our big challenge is that we see more and more cases of acid-related disease that refractory to PPI. Some individuals may not respond well to PPI and may develop the tolerance over the time. Lately, there have been a new development in the field of acid inhibition. PCAB, potassium competitive acid blockers, are the emerging class of acid inhibiting agent that work differently from other PPIs. And today, we're gonna talk about this novel acid inhibiting agent that may offer alternative option that can resolve the unmet need. So today, there is increasing evidence that PCAB, especially normoprasan, can play a major role or can be a game changer in the next chapter for the treatment of acid-related disease. Today, we have two leading international speakers with us here. First, Professor Ratha-korn Vilaichone from Thammasat Medical School, Thammasat University. He's gonna give us a talk on the potent acid suppression with PPIs and PCAB. What is new? And we will follow by Professor Somchai Leelakusolvong from Sriraj Medical School, Mahidol University. He's gonna talk on the role of PCABs for healing and maintenance of erosive esophagitis. So please welcome both of them. The Professor Ratha-korn, you will start first, please.
Thank you so much, Mr. Chairman, for your kind introductions. At the very first, we're going to talk about the potent acid suppressions with the PPI and PCAB. What's new? So my talk going to touch on the history of the anti-secretory agents, the PPI and the PCABs, the clinical comparisons between the PPI and the PCAB for the mechanisms, the anti-acids activity, the safety and benefit, and we're going to grab everything together in the summary part. From the history, everyone, that you have to know that before we go into our present days, we have to went back to the histories. In the 19th centuries, the gastric acids known to be important as many for a physiological process. And in 1905, the gastrin is just known as a gastric acid stimulation. Many 10 years back, in 110, the Carl Schwartz mentions about no acid, no ulcer. But right now, I believe that you have to know that no bacteria, no NSAIDs gonna know ulcers. Histamine gonna know on 1916, H2 blockers in 1972, and the PPIs identify and block search on 1970s to 1980. H. pylori infections cause the stomach ulcers and stomach cancers. Discovered by Barry Marshall and Robin Warrens in 1983, and both of them gonna grab for the Nobel Prize. And the last but not least, the vonoprazan. Gonna first to class of the PCABs available in Japan since February 2015. I believe that Yoshio here is gonna know very well. PPI do not completely inhibit the acid secretions. The PPIs only binds to the available pumps, and then it's going to meal dependence for the maximum effects. Not all pumps are actively at any given times, and a single dose of the PPIs could inhibit only 70 to 80% of the active pumps. We all know that PPI is very short half-life. The half-life is only 1 or 2 hours, and the half-life of the HK-TPS is approximately 54 hours, and 25% of the HK-TPS are newly biosynthesized each day. So it means that the PPIs need the times. It's maybe up to 3 to 5 days and need the repeated dose to achieve the maximum effects. Furthermore, the PPI is not good for the nocturnal acid control, and many of the patients might be suffers during the nighttime attack. Single-dose PPI cannot provide a full 24 hours and inhibits, so the patients may experience suboptimal acid control. And nocturnal acid breakthrough may have the significant impact on societal, financial, and quality of life in many of the patients. When we compare the PCAP PPI, I believe that in here we're going to use the PCAP PPI a lot. What is the difference for the mechanisms? For the PCAPs, it acts directly on the HK-TPS enzymes, but the PPIs require transformations before going to the active forms. The PCAP is a super concentrations in the parietal cells is 100,000 times. For the PPI, it's just only 100 folds higher than in the plasma. PCAP is bind competitively to the K bindings, whereas the PPI is covalently to the HK-TPS. PCAP is reversible, while the PPI is irreversible to the proton pumps. Duration of effects of the PCAPs related to the half-life of the drug in the plasma, then they can give the full effects from the first dose. For the PPIs, duration effects related to the half-life of the sulfonamide enzymes complex, and the full effects may be needs for 3 to 5 days. For the pharmacokinetics of PCAP and PPIs, the PCAPs, we all know that absorb enriching the Cmax within a few hours. And the vonopressans, one of the prototype of the PCAPs, has a prolonged half-life. This means that they have a long-lasting action. And again, PCAP, after the first dose, it can achieve the maximum acid level, but the PPIs take times, maybe the needs to up to 5 days. Acid inhibitions by the PCAP was significantly greater than such as esomeprazole in both day 1 and day 7. I believe that many of you is going to know that PPI is going to metabolize by the CYP2C19, and why the CYP2C19 is used in a lot of the medication, especially for the clopidogrel and along with the PPI. If you use the clopidogrel together with the omeprazole or esomeprazole, the FDA announced around 10 years back that it might be harmful for the patients and some report for the death. So the PPIs can have some defects and limitations to use as for many medication, especially for the Plavix. Unlike the PCAPs, unlike the PPI, the PCAP is used as CYP3A4. So it means that many drugs that use the CYP2C19s may not have any effects or irrespective of CYP2C19 for all of the rapid metabolizers, intermediate metabolizers, and the poor metabolizers. Professor Dux that talk about the HP infections and how to treat these important bacteria. We're going to know that the bacteria may be varying of preference in many countries in ASEAN, varying from 22% in Cambodia of Professor Chakrawut there, and around 70% from Professor Sang Dao, and in Professor Justin Lee, the preference is going to be 20%. In Singapore, Professor Ang here is around 20 to 30%, and in Thailand right now, the preference of the bacteria is going to go for 28%. Professor Amir Khan, I don't know about the preference of the HP in Pakistan. It might be around 1/3 to up to 50%. So HP resistance is going to be one of the important factors right now for treatment of these important bacteria, especially for the keratomycins. I believe that many of you is going to know that if you have a keratomycin resistance, the treatment for the standard triples therapy is going to reduce to up to 50%. And many countries of the world, including Japan, China, Taiwan, Korea, Spain, Italy, Sweden, Bulgaria, Turkey, and in the United States, the prevalence of the antibiotic resistance right now is increasing for all of the keratomycins, the metronidazole and rivaroxaban. such as they have antibiotic resistance for the clarithromycin 50% in China and 30% in Japan. Last year, we present our data in DDW 2022, and we grabbed more than 12,000 cases in the past 20 years for the nationwide survey prevalence rate and antibiotic resistance pattern of HP in Thailand comparing to the ASEAN country. Maybe in 2004, Professor Udom presents the data about HP. At that time, we grabbed the infections maybe up to 40 to 50%. After 20 years later, right now, the prevalence of HP in 2020 in Thailand is just only 24 to 28%. However, even the prevalence of the HP is decreasing, the prevalence of the antibiotic resistance is going to be increasing, such as now the clarithromycin resistance in Thailand is up to 30%. The levofloxacin is up to 26%, and the metronidazole right now is more than 60%. So we are in the phase with the multi-drug resistant situations and believe that we need the good regimens to overcome this resistance. Let's see in the US, from Baylor, David Grams and Professor Yamoka is going to know him very well. The antibiotic resistance in the US, I believe that it's going to pretty much with the antibiotics resistance in Thailand. We're going to face with the clarithromycin resistance in the US more than 30%. Levofloxacin is more than 37%, and the metronidazole is more than 42%. So the antibiotics regimen that can use for treatment of these important bacteria in Thailand is maybe close to the US more than in Japan. That's our next study going to show more in detail. I got many questions asked about HP, why we have to use a protein anti-acid. What is the protein anti-acid? It's going to help for the HP eradications. You know that the main role of the PPI is to elevate the gastric pH to more than 6. And when the gastric pH is more than 6, it increases the populations or growth of the bacteria. And furthermore, when the acid is reduced, the pH is increased, the bacteria is going to be more susceptible to the antibiotic. And furthermore, somehow the PPIs might have a minor of the antibacterial activity. You can see that HP grows in a narrow pH between 6 to 7. And when you got a strong anti-acid inhibitions, it can stimulate the growth of the bacteria. And furthermore, it's going to increase the antimicrobial activities. We know that PCABs OD dose produce the acid suppression equivalent to the very high dose of PPI, even by the esomeprazole and the rabeprazole. And this is going to be the studies show that the efficacy of the first-line vonoprazan containing the HP eradication therapy in 23 report. And they demonstrated that the standard triple therapy, they have eradications only 75%. But the PCABs, it have the eradications rate more than 85%. In the next 3 slides, I'm going to summary the study of the efficacy of the first-line HP eradication, such as Murakami, that published in Gut in 1916, demonstrated that the vonoprazan-based triple therapy have the eradications more than 90%, whereas the PPI is only 75%. Onos in 2017 is a RST trial. The PCABs regimen, they have the eradications more than 90%, whereas the PPI is only 50%. And the last not least, we go to the third page. Osaki demonstrated in 2018, vonoprazan eradications more than 90%, and again, eradications by the triple therapy with the PPI is only 22%. So it means that from the prior study, mostly in Japan, 21 study efficacy showed that the PCAB-based triple therapy that have very good efficacy for HP eradications up to more than 85%. However, this study is going to mostly came from Japan. How about in other countries? In Japan, they're going to have a meta-analysis published in Helicobacter in 2017. And again, they found that the HP eradications with the vonoprazan-based triple therapy have eradication rate is very good, at 85%. And Murakami, as I mentioned before, is found that PCABs is not only have a very good efficacy in first-line treatment, but also in a clarithromycin resistant. The eradications is up to 82%, or even After the first treatment failure, the second line regimen is going to be more than 85% for the eradication rate. Chochusuki published in Gut a couple of years ago. They found that the dual therapy, so we don't have to use the clarithromycin at all. Right now, even we go to the dual therapy with the PPI, with the PCAPs and amoxicillin. But in this study, they can use amoxicillin 750 milligram twice daily. Eradication rate of the dual therapy is pretty good. And even in the clarithromycin resistance, the eradication rate of the dual therapy is up to 90%. It seems like a very high. I'd like to get the information from Professor Ang and Professor Dux that how about the PCAPs in Singapore and in the Vietnam. And again, meta-analysis published 5 years back, mostly from the Japanese study, found that the PCAPs regimen is much better than the PPI in both the clarithromycin sensitive and the clarithromycin resistant. And Professor Liu, Jigme Liu, published the data in Gut several months ago about the vonoprazan-based versus PPI-based triple therapy for the HP eradication from the meta-analysis of 13 studies. The overall efficacy of vonoprazan-based regimen was superior to the PPI in both the intention to treat and per protocol. However, the data is not consistency. If you come to the US, the paper published by William Shea, right, published in the Red Journals a couple of years ago, and the data is from the US and Europe, and randomized control trial with the PPI and PCAP regimens for HP eradication. The N is around more than 300 for each group, and found that triple therapy, yes, definitely, eradications is only 65%. The PCAP triple therapy, eradications is only 80%. It's unlike in the Japanese study that have the eradications more than 95%. And the dual therapy, you can see that from wheelchairs find that eradications is only 77%. But this is a very key study because of this study published in the Red Journals. So PCAP-based regimen of vonoprazan get into the US with the only indications with HP eradication. But they have a very discrepancy between the HP eradications for the PCAPs regimen, comparing between the US, comparing to the Japan. Seems like in the US, the eradications rate of the HP by the PCAP regimen is less than the PCAP regimens in the Japan. What is the reasons or explanation of these situations? As mentioned before, the PCAPs use a CYP3A45 for metabolizers. And again, the clarithromycin also uses CYP3A4. It might be a competitive inhibitors. And right now in Thailand, we use cannabis. I'm not sure about in Singapore or in Vietnam. We are, right now it's not against the law at all for use cannabis, but I don't know. We got a new government as maybe the law is changed. The CYP3A45 is very important, and in some countries, just like in Taiwan, the CYP3A45 rapid nebulizer is more than 94%. What is the importance of the CYP3A4 or 5 rapid nebulizers? They have a study in APT 5 years back about the CYP3A4 genotype status and the outcome of the vonoprazan-based triple therapies for the HP eradication. For the Japanese people in 126 received vonoprazan containing regimens for 7 days. And you can see that in the rapid nebulizers, the vonoprazan-based regimen have the eradication rate only 79% compared to the poor metabolizers, eradication rate is up to 90%. So for the CYP3A4 metabolizer, it might be one of the important factors that can determine the outcome of the HP eradication. So what is a PCAP-based regimen for our experience in Thailand? We just published the data a few weeks ago with the David Grams about the pilot studies of the vonoprazan containing HP eradication therapy. And as I mentioned a few slides ago, that Thailand's results may be similar to the US more than with the Japan. At this time, we grabbed around 100 cases with HP infections, and we divided randomized into 4 groups. The first one is 14 days dual therapy. The second one is 14 days mono triple therapy. The third group is 7 days high dose vonoprazan triple therapy. What is a high dose? In our regimens, we use 60 milligrams of the vonoprazan. And before we go into this study, talk to Takeda and what is the maximum dose of vonoprazan that can allow the safety for the patients. And the information found that 60 milligram is still the safest one. And the last at least one, we use the 14 days vonoprazan triple therapy, but we add more of the bismuth. The demographic data of each group is not different. But the results are very interesting. You can see that the 14 days vonoprazan dual therapy that have eradication only 60%, whereas the 14 days vonoprazan triple therapy is even lower than the vonoprazan triple. It's only less than 60%. But interestingly, when we go to the 7-day high-dose vonoprazan triple therapy, so it means that we use 60 milligram vonoprazan, so eradication rate is go to 92%. Or you can use a 14 days vonoprazan triple therapy plus the bismuth, eradication rate is pretty good. It's come up to 96%. So we'd like to know why it happened. 3 years back during the COVID infections, and we said the first ASEAN Gastro didn't come, that's going to be used online, right? And we developed our lab to do the CYP3A45 genotyping. So in these studies, we go to the CYP3A45 genotyping, and we found that in the CYP3A4 and 5 lipid mobilizers, the dual therapies and the triple therapy is going to be much more eradication rate reduced comparing to the poor metabolizers. However, if you look for the 7-day high dose vonoprazan triple therapy or 14 days vonoprazan triple therapy adding with bismuth, it can overcome the effects of the CYP3A4 5 lipid mobilizers very well. Interestingly, the side effects including the bitter taste, the bloating, the nauseous abdominal pains and diarrhea is just only minor side effects. No serious adverse event was found, and there's no difference between the 4 groups. Next, we have our PPIs, quadruple therapy. How about the vonoprazan quadruple therapies? We present this data by one of our GI fellows in DDMU last year, and right now we submit to Helicobacter this year, and really hope that David Graham's gonna like this paper. So at this time, we grab 100 of patients and divide into 7 days vonoprazan quadruple therapy and 14 days vonoprazan quadruple therapy. You can see that 14 days vonoprazan quadruple therapy, they have eradication rate is 94%. So it's not only the duals or triple therapies for vonoprazan at all. If you have to use a high dose, maybe you can come up with a quadruple therapy that have a very good eradication rate. And again, 14 days vonoprazan-based quadruple therapy can overcome the effects of the CYP3A45 metabolizers very well with a very few side effects. And then, how about the levofloxacin-based vonoprazan therapies? We also just finished one of our GI fellow, Dr. Saran. He just finished last year about the pilot study to identify the optimal durations of levofloxacin vonoprazan-based therapy for HP eradications in the high keratomycins and metronidazole resistant area that are common right now in Thailand, maybe in Vietnam and in the United States. And we name it just like LV HP trials. Now we're submitting to DDMU next year, and really hope that we get a good news. And this time we got 100 cases of the HP infections and go to 2 arms of the 7 days and 14 days of the levofloxacin vonoprazan-based therapy. And you can see that 14 days based levofloxacin vonoprazan therapy, they have eradications up to 92%. So it means that if you want to use the vonoprazan with a normal dose, you can add more of the bismuth. You can go to the quadruple therapy, or you can add the levofloxacin vonoprazan-based therapy. Go to my final slide. What is a PCAP and the PPI? PCAP is a strong acid inhibitions. More expensive, right? Yes, in Thailand and many countries in the ASEAN, we still have only vonoprazan. In Korea, maybe have the other names, but in the Takeda Symposium, I forgot the name of the other brand, right? For a PCAP, as mentioned, stronger acid inhibitions, more expensive and becoming widely available. anyhow, we have wait for a long-term side effects. And this is going to be for a CYP3A45 metabolizers. PPI, that's not really bad for me. It's going to go to good acid inhibitions, but it's going to more long-term side effect. They have many interactions because they use the CYP2C19 metabolizer, especially for the Plavix. And they have many local and originals one. For summary, then David Grams and in the postgraduate course in DDMU in Chicago this year, they summarize the indications for the PPIs and the PCAPs. PCAPs may be better for the high grade of the gut that Professor Somchai can let you know very soon. It might be good for the bleeding of the ESD. It might be used very good in the idiopathic peptic ulcers that we found around 20% in Thailand, and Francis Chan showed that maybe up to 50% in Hong Kong. And maybe in the future, we can use vonoprazan-based therapy for the HP eradication. Mr. Chairman, ladies and gentlemen, for my summary, potent inhibitions of the acid productions is a key pharmacological requirement of the new anti-secretory agents. Current evidence-based suggestion the higher efficacy and safety of PCAPs comparing to the PPI. And the last but least, low of the PCAP as a first line, RT first line for HP treatment could be promising and will be becoming standard for the HP eradication in the futures. Ladies and gentlemen, Mr. Chairman, thank you so much indeed for your kind attention.
Thank you so much, Professor Ratha-korn. We're going to keep Q&A session at the end. So we're going to move on to the second speaker, Professor Somchai Leelakusolvong. Please welcome him. Yeah.
Thank you very much, Professor Udom Kachintorn, for your kind introduction. And first of all, I would like to sincerely thank the organizing committee and also Takeda Pharmaceutical Company for giving me a chance to join this scientific program. My task today is a role of the PCAPs for the healing and maintenance for the erosive esophagitis. I have the following relationship to discuss as shown in the slides. In the next 25 minutes, I will cover the summarize and the management of the gastroesophageal reflux disease. Secondly, I would like to tell you about the updated guidelines and consensus for the management of the gastroesophageal reflux disease. And last but not least, to demonstrate the role of the PCAPs for the healing and the maintenance of the erosive esophagitis patient. The definition of the gastroesophageal reflux disease from the Montreal classification, which was published nearly 10 years ago, is defined as a GERD is a condition which develops when the reflux of the stomach content causes troublesome symptom and or complication. We can divide this is into two groups. The first group is esophageal syndrome, and the second group is esophageal syndrome. It's not a very good one because we didn't have a mount in here. Anyway, you just follow from this slides, and the projector is not very good one. Okay. This cartoon from the Rome 4 criteria show the interplay between esophageal hypersensitivity and the acid exposure in the reflux symptoms spectrum. You will see that the symptoms in erosive esophagitis are dominated by the abnormal acid exposure, whereas symptoms in the functional heartburn are dominated by the hypersensitivity. The symptoms in the non-erosive reflux disease and the reflux hypersensitivity are related to a combination of the both acid exposure and hypersensitivity. Make it simple to understand regarding the esophageal disorder from the Rome 4 criteria. In this table, you will see that in erosive esophagitis, the abnormalities will be seen not only in the EGD findings, but also from the 24-hour pH impedance pH monitoring. You will see that the pathological acid reflux will be the abnormalities as well as the symptom association. But for the non-erosive reflux disease, the EGD finding will be not seen by the white light upper endoscopy, but we will have a positive in the 24-hour pH impedance pH monitoring both the pathological acid reflux and the symptom association. But for the reflux hypersensitivity, the abnormality will be seen in the symptom association, but not for the functional heartburn, which will be negative in all tests. So the major role of the PPI is more predominant in erosive esophagitis comparing with the non-erosive reflux disease and reflux hypersensitivity. In contrast, the neuromodulator drug will play a major role in the functional heartburn more than the reflux hypersensitivity and the non-erosive reflux disease. All of you will already know that the majority of the GERD in Asia is non-erosive reflux disease. Look at this cartoon, you will see that the prevalence of the non-erosive reflux disease is between 83% and 97%. So the NERD remains the commonest manifestation of the gastroesophageal reflux disease in these Asia-Pacific regions. These are the lines for investigation in any patient whom suspected to have a GERD patient, starting from the endoscopy, and I will not go into detail, but the new investigation is in the purple color, that is a mucosal impedance testing, which have a mean nocturnal baseline impedance and post-reflex swallow-induced peristaltic wave index, and also the salivary pepsin measurement. If you look at the esophageal baseline impedance in a patient who have a reflux esophagitis, especially in the erosive esophagitis, we have the baseline impedance lower than the control, and also lower than comparing with the functional heartburn. Can see, okay, of the functional heartburn as well. So in the Lyon Consensus 2.0 that was published in this year also include the mean nocturnal baseline impedance in for the diagnosis of the gastroesophageal reflux disease, like a conclusive evidence for the pathological reflux. They used the Los Angeles classification in grade B, C, and D, but not A. The Los Angeles grade A will be classified as a borderline or inconclusive evidence. And also the abnormal acid exposure, they try to use the higher level of the abnormal acid exposure, just more than 6, will be conclusive. And if the acid exposure time is between 4 and 6, will be a borderline or inconclusive evidence. Moreover, they also add on the mean nocturnal baseline. If the patient who have a reflux disease should have the mean nocturnal baseline impedance less than 1,500, and if the mean nocturnal baseline impedance is over 2,500, this should be against the pathological reflux. This slide shows the list of the management of the gastroesophageal reflux disease, starting with the lifestyle modification and so many things, including the endoscopic treatment and the magnetic system, such as a ring system and surgical treatment. When you face with a patient who have a refractory GERD, what shall we do? The first thing is you can increase the dosage of the PPI to the double dose, or even switching to another more potent PPI, and also maybe using the potassium competitive acid blocker, or changing the PPI timing of the dosing. Or you can add the H2 receptor antagonist or the bisol binder in a patient who have a bile reflux esophagitis, and also can use a GLSR reducer such as a baclofen or the promotility agents especially a patient who have a esophageal dysmotility, or the patient who have a overlapping with the functional dyspepsia. Moreover, the mucosal protective agent can have some role in a patient who have a mild to moderate, or a patient who have to add on the PPI. And last but not least, a patient who have still have a reflux hypersensitivity or the functional heartburn, neuromodulator such as a tricyclic antidepressant might play a major role in this situation. Update of the guidelines or the consensus in this last couple of years, you will see that for the AGA personalized approach, they will recommend that to use the standard dose of the PPI for 4 to 8 weeks. and see what's going on after that. If the patient still respond to the medication, you can tapering the PPI to the lowest dose that can make the patient tolerate with the medication. But if the patient needs PPI more than 1 year, we recommend to test the physiologic testing in that particular patient to see they need to have the PPI long term or not. But if the patient did not respond very well to the PPI, you can increase the dosage of the PPI to be a double dose, or increase or switching the PPI to more potent acid suppressing agent. That is the personalized approach from the AGA. It's interestingly from the Japanese guideline, which the potassium competitive acid blocker was first launched 9 years ago from the Japan group. You see that in a patient who have a severe erosive esophagitis, they will recommend to use the vonoprazan for 4 weeks in the first line, add on with the lifestyle modification and alginate or antacid. If the patient still have add on the symptoms. And in a patient who have a mild erosive esophagitis, they recommend to use either PPI for 8 weeks or use PCAPs, or by using the vonoprazan for 4 weeks and add on with another treatment such as a lifestyle modification or alginate. In a patient who have a non-erosive reflux disease, they will recommend to use just only the PPI for 4 weeks. In a patient in Southeast Asian region, the consensus that it was published by our groups, Professor KL is a reader, and Justin and Duke and me, and so many persons also included in this consensus. We recommend that in a patient who have a mild to moderate, the first line drug should be the alginate, and if the patients still have the symptom, then we might consider the PPI and just adjust the PPI or alginate after the patient have improved in the symptoms. Thai guidelines that was published last year also divided the patient in gastroesophageal reflux disease into 3 groups. The first group, but if the patient have an alarm symptom, just send the patient to undergo the EGD. But if the patient did not have any alarm symptoms, we divided the GERD patient in this group to 3 groups. The first group is a patient who have a typical reflux symptoms. Second group is a patient who have an extra esophageal GERD and the non-cardiac chest pain. The typical reflux symptom may be starting with the standard dose with the PPI, but in the atypical gastroesophageal reflux disease maybe need a double dose of the PPI for 8 to 12 weeks, and if the patient in a typical group is not respond to the PPI very well, you can increase the dosage of the PPI or switching to another more potent PPI, as AGA and American guidelines recommend. So what is the news? The new from this guideline or consensus for the management of gastroesophageal reflux disease, you see that in a mild to moderate GERD, alginate might be an appropriate for the initial treatment and add-on therapy for the PPI. PPI is still the mainstay for the management, which concerning the drug, concerning the long-term safety and appropriate timing for further investigation in whom chronic use is more than 1 year. That should be undergo the testing and address the role of the PCAPs in the Japanese guideline, which I will not go in the detail. And in the refractory GERD, increase the same PPI from OD to double dose fashion, or switching to another more potent PPI or PCAPs. And add on other medication is based on physiologic evidence as well. The PCAPs study, majority of the study are from a Japanese group. Also show that for in a patient who have an erosive esophagitis, PCAP and PPI, which majority of the study using the lansoprazole, is a non-inferiority trial showing that the PCAPs is not inferior to the lansoprazole. And moreover, in a patient who have a severe erosive esophagitis, in 4 weeks and 8 weeks for the meta-analysis, also show that PCAPs is superior than lansoprazole significantly, not only for the 4 weeks, but also in the 8 weeks as well. in a patient who did not respond to the PPI very well, in 124 cases and 13 cases were PPI refractory case which have abnormal acid exposure were switched to the vonoprazan management. You will see that they will record the 24-hour pH before and after using the vonoprazan. In this cartoon, you will see that in vonoprazan group, which is represent a blue bar, and in PPI group, which is represented by an orange bar, the gastric acid exposure time after switching to vonoprazan have a decreasing from PPI to vonoprazan significantly, and not only from the gastric pH, but also the esophageal acid exposure time as well. So in this study, in patients with the PPI refractory GERD, vonoprazan provide the more potent gastric acid suppression, more effective the esophageal acid exposure, and enhance symptom improvement and better esophagitis healing than the PPI. Another study that was by Ronnie Fast that was published in APT this year also showed that in a patient who have a non-erosive reflux disease, which are not which are on the vonoprazan, and see what's going on after that by using the vonoprazan in different doses, such as 10 milligram, 20 milligram, and 40 milligram, and placebo, to see the on-demand therapy of the using vonoprazan in the patient who have a non-erosive reflux disease. In 485 patients with a run-in period and into the 6-week period for using the on-demand therapy and follow up for 1 week, you will see that in this patient, about in 10 milligram, 56% have the heartburn episode, which can have a complete and sustained relief in vonoprazan 10 milligram, and 20 milligram is about 61%, and 40 milligram about 70%, comparing with the placebo about 27%. And no serious treatment at emergent adverse events were reported in all of the 4 groups. So in this study, they conclude that on-demand therapy by using the vonoprazan may be a potential alternative to the continued daily acid suppressing therapy for the relief of the episodic heartburn in a patient who have a non-erosive reflux disease. Interestingly, because this drug was already launched nearly 9 years in Japan, and in Thailand about 4 years. The study, however, a long-term treatment by using the PCAPs, by using the vonoprazan, is a study in Japan, was published in BMC this year. They use vonoprazan. They tend to have a 5-year experience, but the report that was published in the BMC showed 3 years of the using vonoprazan as a maintenance treatment in a patient who have an erosive esophagitis. And moreover, this study have a complete 5 years study already and was presented in the DDW this year. Also show that I will let you know the detail of the study. This is to evaluate the effect of the long-term treatment of the vonoprazan on the gastric mucosa tissue and its safety profile compensate with the lansoprazole patient in a patient who have already healed from the erosive esophagitis. You will see that the arm is a 2-to-1 by using vonoprazan 20 milligram OD for the healing phase about 4 to 8 weeks, comparing with the lansoprazole 30 milligram. And in the maintenance phase, 202 patients entered this maintenance phase, and finally, at 260 weeks, vonoprazan, the number of the patient is about 105, and from the lansoprazole group is 53 cases. This is a baseline characteristic in this both group is pretty close, similar, no different in these 2 groups. For the histopathology, they will look at the neoplastic or the dysplastic change. They will look at the parietal cell protrusion. They will look at the foveolar hyperplasia and also the G cell hyperplasia, and also the enterochromophin cell hyperplasia as well. The result is show that in this histopathological change of in both groups, no neoplastic change, including the neuroendocrine tumor. However, the foveolar type of the adenoma and the case of oxytic gland adenoma in both groups had been reported by year 4. At the week 20, at the end of the study, about nearly 5 years, the incidence of the parietal cell protrusion or the PCP and the foveolar hyperplasia is higher in the vonoprazan group comparing with the lansoprazole group. And there were no significant difference between the groups. And also, if you look at the cumulative incidence of the PCP or the G cell at the week at the end of the study, and also no significant difference in the cumulative incidence of the ECL cell hyperplasia as well. In the endoscopic findings at the end of the study, the cumulative incidence rate of the endoscopic detected erosive esophagitis recurrence was about 11% in the vonoprazan group, comparing with the 38% in the lansoprazole group. And moreover, a patient who received vonoprazan had a numerically higher incidence of the hyperplastic polyps and cobrostome mucosa comparing with the lansoprazole. However, the patient who received the vonoprazan have a numerically lower incidence of the Van hyperplasia and multiple fat and elevated lesions comparing with the and also the back spot and also the gastric polyps comparing with the lansoprazole group. None of these different were statistically significant. For looking at the serum gastrin and chromokinin A, you will see that in the red bar, that is vonoprazan comparing with the black bar, black line from the lansoprazole group. The upper panel is a serum gastrin and the lower panel is a chromokinin A. You see that vonoprazan have a higher serum gastrin and chromokinin comparing with the lansoprazole group. And mean serum pepsinogen 1 and mean pepsinogen 2 were also higher in the vonoprazan group than the lansoprazole group. And for the adverse event in the 5 years period, adverse event occur in nearly 93% in the vonoprazan and 95% in the lansoprazole group, and mostly are mild to moderate. And 3 serious adverse event related, but I cannot catch the detail from the study that which is a serious adverse event in the vonoprazan group, but none in the lansoprazole group. If you look at the meta-analysis that just was published this year, reporting about the incidence of and type of the adverse event in a patient who taking a vonoprazan. In the study of the Helicobacter pylori eradication in a patient who have a reflux disease or a peptic ulcer disease or ulcer line after the ESD, you will see that any adverse event is maximum is not existent. It's just only in the peptic ulcer that go to the 47%, but majority is not existent 20%. And the related adverse event is about not existent 10%, and serious adverse event is about 0 to 4%. And the adverse event leading to the drug discontinuation about maybe not existent 3%. So in general, this is quite a safe drug. The most frequent adverse events are the diarrhea or the nasopharyngitis or dyspepsia or headache and abdominal pain. So in this study, the conclusion is no new safety concerns were identified in Japanese patients who healed the erosive esophagitis receiving the vonoprazan or lansoprazole as a maintenance treatment for the 5 years. The last study that was published in the Gastroenterology this year also from the Rolanian group, they used vonoprazan versus lansoprazole for the healing and maintenance of the healing of erosive esophagitis, a randomized control. You see that in a healing phase, about 8 weeks, by using the vonoprazan 20 milligram comparing with the lansoprazole 30 milligram, the benefit in the healing, and also after that another 24 weeks for the maintenance phase by using lansoprazole 15 milligram, vonoprazan 10 milligram, and vonoprazan 20 milligram. The difference of the the healing rate in the healing phase, when you look at the vonoprazan group, is about 92, have more than the lansoprazole group, that is 84, that is about 8.3%. Moreover, in a patient who have a severe erosive esophagitis, such as our Los Angeles classification C and D, this difference is more nearly is higher than the difference in all patients, is close to 20%. And more interestingly, in the maintenance group, comparing with the 10 and 20 milligram of vonoprazan and the lansoprazole 15 milligram, you will see that the difference in 20 milligram is higher than in 10 milligram. That is about 7.2 and 8.7%. And in the patient who have a severe group, severe erosive esophagitis, it goes from 30% to 15%. So in this study, vonoprazan was not inferior and superior to the PPI, lansoprazole, in the healing and maintenance of the healing of erosive esophagitis. The benefit was in predominantly in more severe erosive esophagitis. Mr. Chairman, ladies and gentlemen, I would like to summarize that the vonoprazan was non-inferior and superior to the PPI, lansoprazole, in healing and maintenance of the healing of erosive esophagitis in patient negative for Helicobacter pylori infection. Furthermore, the difference in the favor of the vonoprazan was greater in the patient who have a severe erosive esophagitis, such as LA grade C and D, than in those with the mild erosive esophagitis. Safety concerns were identified in Japanese patients receiving vonoprazan or the PPI as a maintenance treatment for 5 years. Thank you for your attention. On behalf of the Congress President, I would like to invite all of you to join the APDW in Bangkok this year, December 6 to 9. Thank you. Thank you very much.
Thank you so much, Professor Somchai, for your excellent presentation. I think we only have 1 or 2 minutes, so I will take 1 or 2 short questions, please. Yeah, please.
I would like to thank two speaker for very informative and updated information lecture. So I have one question for Professor Somchai. So for the acid suppression, we can control the heartburn symptom. So the challenging is now is the regurgitation. So in real life practice, when we use acid suppression, sometimes we can, most of the time we can control the heartburn. But how about regurgitation? Could you express and share your experience in your real life practice? Thank you.
You will see that in only one study that using the vonoprazan as an on-demand therapy. This is not surprisingly me, because personally I also use it, because if you look at the data that Professor Ratha-korn already shown you, that after taking this medication, the acid suppressing agent will be achieve the pH 6. Is not only as a PPI that need about 4 or 5 days to achieve the steady stage. But in this medication, they can achieve in the first day. So that's why when we use the like a on-demand therapy, that's why the patient still have a relieving of the symptom of the heartburn. And moreover, if you look at the pKa of the PCAPs, especially for the vonoprazan, is go to the 9.4, which is a very high pKa. That means that they can act to suppress the acid production quite quick, comparing with the other anti-secretory agents. Not only for the mechanism of the acid suppressing, but in a patient who have a heartburn, another things such as a hypersensitivity or another mechanism might be can respond to the patient as well. That's why when we use some mucoprotective agents such as alginate, the patient can report that they get relief from the symptoms not I don't think that not that is from the acid exposure alone, but maybe from the reflux hypersensitivity, or maybe from the contractility of the muscle, maybe have a contribution to these symptoms as well. Yep.
If no more question, I think we have learned a lot from both professors that potent acid suppression is a key in the effective treatment of the acid-related disease. And the emerging PCAP, especially vonoprazan, have a very good candidate. It has more rapid onset of action. It has a longer duration of acid suppression. And last but not least, it has a more effective treatment of the acid-related disease. So please, once again, would like to thank to our two speakers. Thank you so much.